Dr. Alan Zajarias to share insights on how our understandings and treatments of heart valve disease has evolved dramatically and what the next frontiers are. Let's welcome Alan Zajarias.
Well, thank you, Patrick, for that brief introduction. Thank you to Dassault Systems for inviting me to present here with you today. I was tasked to talk to you about the use of computer simulation in the cath lab. And when I try to make this talk, I try to first put ourselves in a certain situation that allows you to understand where I live or where people like me live, so we can then pose questions to you, the engineers, and then together we can come up with a good solution. So I'm a practicing physician, I'm a cardiologist, I see patients once a week, and they come to see me when they're not feeling well, or they come to see me to ensure that their health will continue as time goes by. Other days of the week, I'm actually an interventional cardiologist. So I change my regular clothes and I put scrubs, and I bring patients into a procedural suite where we've developed techniques where we can take a look at the arteries that feed the heart, and then if there are any narrowings of them, we can then go ahead and plan to put a stent or things of that nature to improve symptoms, improve survival if patients are having a heart attack. Other days of the week, I'm a valvular interventionalist. So the field of interventional cardiologists has grown in such a way that now we don't only treat coronary arteries, but we have taken patients who previously only were able to undergo heart surgery and then take those patients and perform surgical-like results with a catheter-based procedure, which means we can repair or replace a valve by a small incision in the groin or one of the major arteries. Now, in order for us to be able to do that, I am a closet imager. And what that means by that is that instead of me just going in the procedure room and doing my procedure, I take the CT scans or I take all of the imaging modalities that we're able to use to plan for our procedures. And this step, I believe, is the one step that allows us to allow for patients to be treated effectively without then incurring on complications. And as a result, that is likely the most important aspect of what I do or people like me do for a living. Now, the question that I have to ask myself is, well, what keeps me up at night when I think of my procedures the following day or when I think about my patients who I'm going to be treating the following morning? And as you can see, the major item that I worry about is how can I avoid complications? All interventional cardiologists and even surgeons have actually been given the task or given the skills to allow for improved life-saving procedures. On the other hand, if these procedures go wrong, they could easily be life-threatening. And it is our role to make sure that we avoid things that can be avoided, or we can maybe plan ahead and say, okay, if we are encountering this complication, maybe we should do steps differently in order to allow for outcomes to be appropriate. I want to minimize procedure time. Patients are sick. They're very vulnerable when they come to see me. They're very vulnerable when they come to see us in the procedural suite. We then take them away from their family members, put them in a very cold and stale environment that is a procedural suite, and patients don't really like that. And what is it that I can do to make that experience more comfortable, but more importantly, shorter, so I can bring the patient back to their family members in a better shape? And that is actually the second thing that keeps me up at night. How do I maximize procedural efficiency? At this time when cost is an issue, when we have so many different skills or tools to treat or choose from, I want to make sure that I select the right tool so I don't necessarily have to utilize 2 or 3 different tools to allow for the same result. And finally, how do I improve my preoperative planning? How do I make sure that the moment that I step into the procedure room, I do what I need to do, we then take the patient out of the procedure room and go back into a normal state. And if we're able to do that, then I think we are advancing science and we are advancing medical care to the best of our ability. And that actually is what brings innovation to the cath lab, or pretty much for any other environment in general. We bring people together, people of different expertise, with a patient-centric experience. We find what the problem that the patient is encountering, and then we bring everybody together to then allow for us to find a solution. We bring the engineers to come up with some incredible technology. We bring industry to allow to develop that technology. We bring buy-in from the hospital systems or the physicians to allow to provide care at a much higher level with improved outcomes. And then obviously we have to bring our government partners that allow for the appropriate regulatory pathway. So we don't fall into areas that are unapproved, or more importantly, that we work together to gain access in the right way in the different environments. And if we can do this keeping the patient in mind as the first and most important step, we will be very successful in allowing to innovate in the cath lab. Now, as I said earlier, we're able to do a lot of different procedures, and the pre-procedure innovation probably is equally as important as the innovation that we do afterwards. In the field of transcatheter aortic valve replacement, which means that we're able to take a patient who has severe aortic stenosis or narrowing of one of the heart valves, instead of taking him to the operating room, we bring him into a procedural suite where we give him some local anesthetic, give him some sedation, and then through the artery that feeds the leg are able to replace the valve routinely. Patients, instead of spending 5 days in the hospital, 2 of those in the intensive care unit, and then 3 months worth of rehabilitation, they go home the following day and start working on their day-to-day activities within a week or a week and a half. So this is now the most common way of aortic valve replacement that we encounter in the world. Now, since this is a new technology that's been available for a short amount of time, we've been asked as practitioners to create a database where every patient that undergoes a transcatheter valve procedure is then entered. And that way, the government and payers and all of us are aware of what our complications are, but more importantly, we set a standard on what we can do. On the other hand, all of our patients who get a transcatheter valve replacement undergo a CT scan with contrast, similar to what our colleagues from Bordeaux just mentioned. And it's this CT scan that allows us to give a certain size for the valve, a certain access route for the valve, and that allows to have an incredible powerful amount of imaging technique behind all of our procedures. Now, as this procedure has evolved, our complication rate has dropped dramatically. But there are still some complications that happen very infrequently that have a very high impact in mortality or morbidity. Specifically, the risk of a stroke has gone down from 8 to 10%, down to less than 2%. But we still have a small amount of people who encounter these devastating complications. And it doesn't matter how experienced we are. It takes a very large population-based study to allow us to gain access into the nuances that may actually identify the risk factors that predispose people to this stroke. Now, the good news is that we have the ability to do so. The bad news is that we haven't necessarily found the right way to interconnect our TVT data set, which is totally clinical, with our CT data set that is actually housed in servers from Dassault Systèmes. So we currently are looking for a way to merge these aspects, obviously by maintaining HIPAA and following all of the appropriate guidelines, but in order to allow to make a more powerful data source, so then we can predict complications from occurring and then potentially treat them ahead of time or avoid them from occurring. On the other hand, we've been performing procedures like coronary angiography since the early 1970s. And these procedures have evolved a fair amount, but the one thing that has not evolved is the way that we consent patients. You know, I walk into a procedure room in the holding area, I introduce myself to the patient's family, and I come up with some sort of blanket statement that the procedure you're going to get is relatively safe. We're going to do it this way because we think it's safer. But from a population-based perspective, this may be good enough. From an individual perspective, if I'm the person having a procedure performed, I'm 100% of the effect of what's going to happen. I'm not the 1% of him going to have a stroke, or these consequences can be really devastating. And as a result, we need to take a step back and change the way we address consents. Consents have to be personalized today because we have the ability to do that. We have the ability to predict who's going to have that issue or what type of patient factors influence our outcomes. So it is on us to make sure that we do that and we make this much more personal in order to not only tailor therapy, but tailor risk and then compare outcomes before we even get started with what the procedure is all about. Now, in the field of interventional cardiology, we need contrast, or this iodinated material, to take a look at the arteries that feed the heart. And contrast is an incredible tool. However, it can come with some risks or complications. If we administer contrast and the patient has certain renal dysfunction or certain characteristics that predispose them to renal failure, this may precipitate that. And in the grand scheme of things, it doesn't happen as frequently. However, in the United States, it happens between 10 to 12% of the time in the median of our NCDR databases. And if you take 2 million catheterizations that are performed every year, and we estimate that 10% of these patients will have this complication, and then we factor a cost of between $9,000 and $10,000 per case that we encounter into that component. If we're able to prevent complications, we're going to be saving over $2 billion in a matter of no time. So at our institution, we decided to take an active approach on how to do this. And we came up with some factors that are very much well known as far as what are the risks that predispose people to develop renal dysfunction after a coronary angiogram. And the number one factor that we came up with was the amount of contrast that is being administered. So contrast is needed, but at the same time, it could also be really, really toxic. At the same time, we were trying to make sure that we find, is there a way to individualize the amount of contrast that we can use as a maximal tolerated dose in these patients, so then we can safely do a procedure and then prevent them from having a complication. And at the same time, if we're doing a very large procedure, maybe we could divide it up in 2 different settings. We could do one, we could wait a couple of days for things to normalize or prevent from occurring, and then go ahead and give a second contrast dose later. And we've actually been incredibly successful in finding that. We've been able to take regular data from the electronic medical record. We input it into a model that allows us to decrease the rate of AKI to around 4% and give us a workable amount of contrast to be utilized in order for us to be able to then perform a procedure relatively safely. And with that, what the hospital has won from that is, the accolade of being a best performer. But from a patient satisfaction perspective or a patient's health perspective, patients now know that you can look for these type of institutions that may allow you to have that benefit. And this may likely catch on in insurance companies or things of that nature that would give you a preferred status on whether or not your procedures may be actually funneled into hospitals that have these least amount of complications. Now, the interesting thing, though, is that all of this data is available in the electronic medical record. And we just need to find a way to take it out of the medical record, input it, and then come up with an answer that'll help all of us in a very exciting way. And right now, we're in the process of actually incorporating into the EMR, so we don't necessarily have to depend on an individual to extract that data to give us that information. So more to come on this, but it's something that is definitely paving the future. From a procedural perspective, if we change gears again and we talk about the mitral valve, the mitral regurgitation is a process in which we have leakiness of the mitral valve. The mitral valve connects the upper left pumping chamber of the heart to the bottom left pumping chamber of the heart. And it is the most common valvular heart abnormality in the Western world. Traditionally speaking, patients have this problem and they're very healthy and they're able to withstand traditional open heart surgery without any limitations. However, for those patients who are too risky to have traditional open heart surgery or who have, quote unquote, an elevated operative mortality, a procedure called a MitraClip or a transcatheter edge-to-edge repair was created. And this procedure basically takes a clip, as you can see here on the bottom part of the screen, and we bring that clip into the area where the mitral valve is, and the mitral valve then has 2 doors or doorlets that rest nicely in between those arms of the clip. And once we have enough mitral valve there, we close the clip together, and by doing so, that decreases the amount of regurgitation by bringing the leaflets together. Now, this is a procedure, as I said, that's open for patients who are considered high risk, and if done correctly, increases survival, decreases heart failure hospitalizations, and makes people feel better. These are all the 3 things that people look for whenever they are ill. But at the same time, if we don't do the procedure correctly, or if we end up having a result that is incomplete, we are not going to help the patients, or we could even promote a deterioration of their health status. And that is where creating a simulated model of what the mitral valve looks like can actually create or ease our procedure. So this is work that we've been collaborating with Tom Battisti and Zajarias here at Dassault Systèmes. And what you can see here is a en-face view of the mitral valve that has an anterior and a posterior leaflet. And then you have a side view of the mitral valve as well. So this valve opens when the upper chambers of the heart fill the blood of the bottom chambers of the heart, and closes when the bottom chambers of the heart contract. And as you can see in this image, the valve has the leaflets and also some cordal apparatus or parachute cords that actually prevent the valve from moving into places that are abnormal. When we bring a MitraClip, when a patient for a MitraClip procedure, we basically are bringing a clip or a piece of rectangular nitinol component that grabs the leaflets together, and by doing so, we make the leaflets coapt appropriately. The average individual who gets this procedure decreases the amount of regurgitation by 2 grades, which means we go from severe down to mild to moderate or mild. And the limitation of this procedure is that we can tend to make the valve too small if the valve is not too big to begin with, or if the pressure difference between the atrium and the ventricle is very elevated to begin with, and we then close the valve even more, we will create a problem of mitral stenosis, which is worsened. Now, by doing this procedure, by doing the simulation, we can potentially predict whether or not we can get the result that we want with 1 clip. We can even move a clip, or we can actually have 2 clips together. And the idea is that we will select the patients, the location of the clips, the type of clips that we can use without actually impacting the patient negatively. And on the contrary, instead of trying to guess, to say, okay, we're going to put a clip right in the middle and then see what happens, we can then come with the procedure in a much more educated fashion and say, hey, maybe if I put a clip a little lateral to this component and maybe a second clip on the other side, we will be able to have a better result. Now, this is still really early on, and this is definitely very exciting, but the results are so far somewhat favorable. This is an echo view, as you can see up top, of the mitral valve in diastole when the heart is opening, and then on the other side is in systole. And you can see the hole that is in the bottom right part of the screen. That is the area of regurgitation. So in theory, in a patient that may have this problem, you can actually clip the valve and then come up with a relatively good result without any significant regurgitation. As you can see here in this view, which is the true patient rendition of the previous simulation, on the area on the left where it says pre-MitraClip, this is a 3D and fast view where the color of the color jet is coming from the ventricle into the atria, and as a result, that's mushroom part of cloud. And on the bottom right, if you wouldn't mind activating that video, that would be very helpful, please. You can see that after the clip is placed, the leakage is gone. So this procedure is very successful. The patient did really, really well and is doing much better. So if this really works, what are the implications? First of all, we can have the appropriate patient selection in order to make sure that the cases that we do are appropriate. And what I mean by that is patients will end up with the least amount of reduction, with the least amount of regurgitation with a quote-unquote surgical-like result. And we could even avoid the unnecessary step of going to a procedure and aborting the procedure and maybe think about something else that may be able to help them over the long run. We'll increase procedural efficacy. We'll be able to select, am I going to use device X? Am I going to use device Y? Can I use a combination of both? Do I use the wide clip, the long clip, or somewhere in between? And that'll tell me who is the patient best suited for the procedure that I can be able to generate. And finally, it'll decrease the procedural time. You know, the procedural time is a factor because it involves patient time in the room, research utilization, physician fatigue, things of that nature. And the least amount of time that we spend and we take patients away from their families, the better off we are. And also, if this is able to work out appropriately, can you imagine being able to go to the FDA and say, hey, I have this model that allows you to test procedures or devices before they get marketed. Can we decrease the amount of time it takes for a device approval, as long as we don't sacrifice its efficacy or safety? Can we decrease the amount of patients that are needed to enroll in a clinical trial that will be incredibly costly to allow for the appropriate endpoints. And if that's the case, this will create a lot of traction so we can go ahead and move forward on innovation at a much faster speed. So simulation can be utilized in every step of the evaluation process in the patient care, in the pre-procedural component, while in the procedure, and even afterwards to improve our overall outcomes. In the collaboration with the key stakeholders that are likely in this room and anywhere else, with a simple question to be answered, with a patient-centric approach, will always improve to appropriate innovation. And I think the use of simulation, new device testing, has the potential to facilitate the approval process and improve patient selection for all of our procedures. And I'd like to acknowledge Tom Battisti, Jiang Yao, and David Hoganson for inviting me to participate in their mitral valve project. And I also collaborate with the research and development of flow dynamics and the coronary artery flow and related topics with the team here at Dassault. So I'm going to stop here, and I don't know if there's any questions.
Thank you very much, Alan, Dr. Zajarias. One question, I may start. Up until now, I thought the value of virtual twins basically to rehearse before doing the actual work. But what you show with the one-clip, two-clip option, and maybe there's more, do you see this rehearsing in virtual being an inevitable and forced phase before going to the block?
So the use of a simulation or the use of a model like the virtual twin is incredibly helpful, as you said. When we encounter complicated procedures, particularly in the congenital heart disease world, or even in patients who have very complex anatomy, it's always helpful to go ahead and do it and practice that way. One of the key pieces that I think is very important is in the education. I train fellows who eventually become incredibly phenomenal cardiologists and cardiac surgeons, and the ability for me to transfer my knowledge into their hands, or for them to develop their own knowledge into their hands, is definitely facilitated and improved by the use of this type of model. So in medical education, this by far is going to be an incredible task. And potentially in the tackling or in the role of every procedure, yeah, there could be a good place for it.
Because families would even ask you before, have you tried everything before?
Correct. Now, unfortunately, we can't 3D print everything, right?
Exactly.
And not every model is perfect, but it is definitely something that is reassuring when you say, I've tried this a couple of times in my video game, and nothing's happened yet.
Thank you. Any questions from the room? One here. If we have the mic coming.
Thank you, Doctor, for this amazing presentation and your message about patient-centric approach in all the protocol and procedures. As a specialist, at the end of the day, I suspect that whatever simulation you use, you are going to be the decision maker in the surgery room when you actually do the practice that you have decided to do, like selecting a one clip to two clip and so on. How this, in all the experience that you have you changed your mind between the reviews on the pre-op options and then when you actually are doing the practice in reality based on certain observation, and are those observations then captured to accumulate this kind of learning curve? Because I do appreciate very much, as you can imagine, the quality of know-how, not only knowledge, but the know-how that your job represents.
So, that is a really important concept that you just mentioned. All of our models or all of the simulation can only be so accurate. And there are many other factors that are not included in the model that come into play on a day-to-day activity. So yes, it is incredibly important that we make our assumptions with the models that we have, but still have the ability to change our mind when we see something that doesn't quite apply to the model that we do. So we do that routinely. If you go back to the coronary world, we make some measurements of invasive hemodynamics called fractional flow reserve assessment or instantaneous flow reserve assessment. And those measurements can tell us when a narrowing is intermediate by visualization, if it is truly severe from a physiology perspective. And sometimes the measurements don't add up. Sometimes the measurements tell us that a narrowing is very importantly narrowed when it does not look importantly narrowed. And that could be that there's a measurement error, and that's really important for us to realize. Or sometimes the opposite is true, that the narrowing looks really severe and the physiology doesn't tell me that I need to stent it. So that's where I do think that it's incredibly important to realize that all of these are tools that will help us make a decision and treat a patient. But at the end of the day, we cannot depend solely on the tool, and there has to be some sort of common sense in what we do. So yes, I think to answer the question in a long-winded way is it happens routinely, and it just has to make sure that we really take a step back and understand what information is being given and how we can interpret that appropriately.
Human natural intelligence always has the mic.
Yep.
Thank you very much, Dr. Alain Zajarias.
Thank you.
Thank you very much.